and it's my pleasure here to share with you a little bit and to slow down our heart rate. I was listening to all the emergency rupture aneurysms, and my heart rate is also pretty fast. So today I'm going to share with you a little bit about prevalence of AAA in our Asian population. And my name is Joseph. I'm a vascular surgeon from Singapore. These are my disclosures. So we all know Ip Man, and we all know that Ip Man fought the West. When I was training as a fellow in 2016 in UK, we would do 2 to 3 EVAs every week. We would do 1 to 2 FEVAs every week. And there'll be 1 to 2 open aneurysm repairs every week when I was training in UK in 2016. But when I returned to Singapore more than 10 years ago, and when I looked at our numbers for the past 12 months, at our center, we did more than 800 vascular operations, both open and endovascular, and out of which aortic surgery constituted about 11 patients, or there were 11 cases, less than 1%, very similar to what we hear from Dr. Chan earlier on, and also Dr. Liang in Macau and in Hong Kong. So the main thing that we do know anecdotally is that there is a difference between the West and the East in terms of the aortic prevalence. This is the European Society for Vascular Surgery guidelines, and if you look at their fine print, it says that there's a very low prevalence of abdominal aneurysms in subjects of Asian ethnicity, and this is based on the various RCTs for patients who undergone aortic screening. So the challenge for us in Asia is that the background prevalence, it seems to be lower than in our Western counterparts, and hence we cannot copy and paste the strategies, and we might need to consider some form of risk-enriched screenings or subgroup screenings for relevant Asian populations. Now, most of us will be familiar with the MAS trial, or the multi-center aneurysm screening study from the UK. They had a large population of 67,000 patients. It started in 1997, the study, and the UK aortic screening started in 2009. And at the 13-year follow-up publication in 2012, they do demonstrate a 42% reduction in AAA-related mortality for patients who go through screening. And if you look at the rates of rupture aneurysm repairs in UK across the years, you do see a decrease in the trend, not only because of screening, but also probably because of a reduction in smoking rates amongst the population. Now, in the US, if you look at the US Preventive Services Task Force, they look at all the various randomized control trials looking at abdominal aortic aneurysm screening, and screening does reduce AAA-related mortality with an odds ratio of 0.62. So is screening helpful? Yes. Does screening reduce mortality rates? Yes. However, if we take a deep dive at in the participants in all the randomized control trials, if you look at it, it's about 186,000 patients, and the prevalence of aneurysm was anywhere between 3.3% to 7.6%, especially amongst males and more than 65 years old. So, within the literature, as what Chairman had alluded to earlier on in his opening speech of the conference, is that a lot of our data are based on Western data. They're based on patients of Caucasian origin, and hence we do need a little bit more data from our Asian population. Now, if you look at the systematic review of AAA prevalence around the world, and you can see that just simply by the dots, the red dots and the green dots, most of the data is based from Europe, and we do have a lack of data, especially in Asia. We do have some data from East Asia that we look at. From China, 2014 and 2015, from Guangdong General Hospital, in about 1,500 AAA screening, we see that overall prevalence was about 1.6% lower than that in the Western population, but in males of more than 65 years old, it's 2.9%. multiple variables to increase the risk of aneurysm, as we all know: age, smoking, hypertension, aortic diameter of more than 30 millimeters. And if you've got 4 of these predictors, the risk can go up to about 10% amongst this high-risk population. In Korea, they looked at screening through a transthoracic echocardiogram, and the prevalence in patients who are more than 60 years old was about 2.9%, and in male that increased to 4.7%. And once again, when they did a multivariate analysis, the usual suspects came out: age, male, hypertension, diabetes, hyperlipidemia, chronic kidney disease, coronary artery disease, and previous smokers. When we look at Taiwan, they looked at their database from a national database, and the overall prevalence was about 2.9%. And in 2011, sort of the prevalence increased to about 4.2% across the island. Now, we do have a slightly older paper from Professor Stephen Cheng in the early 2000s, whereby he looked at the aneurysm rates in Hong Kong through the database, and the overall prevalence was once again 1.4%, with patients more than 65 years increasing to about 10.6%. And lastly, if we look at Japan, overall prevalence in the AAA Japan study was about 4.1%, and expectedly for patients who are male, who are even more than 80 years old, it goes up to 9.2%. As usual, when they did the multivariate analysis, age, males, gender, previous smoker or current smoker, history of coronary artery, and also peripheral arterial disease, they are all risk factors for the development of AAA. Several years ago, my group, we did a systematic review and looked at the prevalence of AAA in Asians specifically. We looked at 17 studies, a total of about 115,000 patients. Most of the data were mainly from East Asia, from Japan, Hong Kong, Korea, and China, including some of the Western data sets with a subgroup analysis of Asian population. When we did the forest plot, we did a meta-analysis, what we found was that the overall prevalence within Asian population was about 1.3%. But if we do look at the various cardiovascular risk factors, patients who are smoking, hypertension, ischemic heart disease, a previous stroke, peripheral arterial disease, and a family history of aneurysm, the prevalence does increase to about 2.56%. Now, so many numbers out there. You've heard that in the Western populations, anything between 3 to 7%. In Asian populations, sounds like something less than 2%. And if you go back to our medical school in public health, WHO, Wilson, and Jonger's classic screening criteria, there are many things that we look at to consider screening within our population. It needs to be important, it needs to have diagnosis facilities, you need to be suitable for a certain test, you need to understand the natural history, etc., etc. And in our Asian population for AAA, in general, the question is whether is it a big enough health problem to institute some form of screening amongst our population. And in general, any prevalence of more than 2 to 3% probably justifies a screening within as a public health system. So within our population, although the overall prevalence is low, we do see patients with similar risk architecture. Patients who are elderly, more than 65, males, previous smoking, patients who have hypertension, patients who have coronary artery disease, patients who have peripheral arterial disease, patients with COPD, and also family histories. So these are specific risk factors that we do have in commonality with our Caucasian counterparts. So as a challenge, given that we are a academic alliance youth forum to our young ones, how can we institute some form of AAA screening in Asia? Definitely not like the Western population, not just male, not just more than 65 years old, but perhaps you can look at the specific subgroup of patients who are 65, male smokers with cardiovascular risk factors. And this is where you can consider hypertension, you can consider coronary artery disease, peripheral arterial disease. you can consider screening them perhaps opportunistically in the cardiology or the vascular clinics when they come in for peripheral arterial disease. And the older hypertensive gentlemen, especially smokers, we do have Chinese and Japanese data to support this, and also specifically patients with a family history of AAA. Perhaps for patients who go through a transthoracic echocardiogram or vascular ultrasound, there can be a case for opportunistic screening in this high-risk patient. Now in Singapore, one of our colleagues in the National University Hospital, they have started a study to offer 1,000 patients who are male, 65, smoker, with coronary arterial disease, and to undergo a AAA screening, and probably we'll have the results in the next 2 to 3 years. So ladies and gentlemen, in conclusion, with regards to abdominal aneurysm in Asians, the prevalence amongst Western population is as high as up to 7%. Within the Western population, AAA screening has significantly reduced mortalities, as we have seen in the Western literature. And amongst Asians, the prevalence overall is relatively low at about 1.3%, so perhaps not such a big so-called public health issue, but for patients with cardiovascular risk factors, they do have a much higher prevalence of abdominal aneurysm, up to about 2.5% or 2.6%, and hence the challenge as a group for us, probably we can look at national databases, and we can then develop something which for high-risk subgroup Asian populations, perhaps age, male with significant cardiovascular risk factors, opportunistic screening may be amenable for these patients. So with that, I thank you for your time.